Todd, how are you doing?
I'm doing well, thanks. How are things with you, David?
Things are great. Things are great. And I thought I might mix things up a little bit today. And that's why I thought I would start off because I think we've got some things to talk about that I think it would be really helpful if we interviewed you because I think I see you as the ASN source on some of these issues. How do you think about that?
Well, depending on the topic, it seems like a good idea, but I reserve the right to say no comment. How about that?
That's fine. I am completely sure of myself that these are topics that you know better than anyone else at ASN, and that you do truly enjoy engaging in.
Okay.
And they have to do with. I'll just tell you, it's going to deal with ABIM and ACGME, and a lot of the outreach you have been leading with us with those two bodies. And so I was just going to ask you to start us out with just kind of as much as possible, kind of like what is the role of the two of them in specialty medicine?
Yeah, it is. It is an interesting topic, and it is something that I've been spending a lot of time on. So maybe just to set the landscape here. So the American Board of Internal Medicine is one of 24 certifying boards within the American Board of Medical Specialties. And the way to think about ABIM is it's general internal medicine and hospital medicine and geriatric medicine, as well as all the subspecialties of internal medicine, including nephrology. So the people that they certify are called diplomates, and they certify about 200,000 diplomates. And of those, there are maybe 10,000 nephrologists. So, we're about 5% of their business. So I think that's just sort of the first piece. The second piece is, over the last 20 years, there's been an effort really to include a recertification component. So you complete training in nephrology, you certify in nephrology, and then every 10 years you need to recertify. And there's a process that we can talk about to sort of maintain your certification. The Accreditation Council for Graduate Medical Education is structured a little differently. So where ABMS and its 24 boards are much more sort of in a Jeffersonian model, or much more of a decentralized model. The ACGME is much more centralized in the sense that there's the overall ACGME, and then within it they have what they call review committees for different specialties, and including internal medicine. And then within internal medicine, one of the individuals who serves on that review committee is a nephrologist, Ruth Campbell, who's at the Medical University of South Carolina. So slightly different. That's a much more centralized or Hamiltonian approach. So that's kind of the two organizations. And what ACGME does is accredits residency programs and fellowship programs. So for our purposes, internal medicine residency programs, pediatric residency programs, as well as nephrology fellowship programs and pediatric nephrology fellowship programs. The other sort of player in this environment that's not as relevant for this discussion, but just to put them out there, is the Liaison Committee for Medical Education, which is responsible for accrediting medical schools, so undergraduate medical education. So the way to think about it is LCME to ACGME, and those two are accrediting institutions and programs, and then to ABMS, in our case ABIM, which is certifying individuals. Let me stop there and see if you have any questions about that overview.
Okay, actually, that makes a lot of sense, and I had wondered how to look at it. So basically, you're saying look at it. One is really dealing with the organizational accreditation. The other one is dealing with the individual practitioner. Is that correct?
Yeah. And the terminology is, for the programs, it's accreditation, and for the individuals, it's certification. And so that sort of helps you keep consistent here as you think about things.
I know that ASN recently received requests, or I believe we referred to them as invitations, from ABIM and ACGME that led to a lot of internal discussion and to a response to the two organizations from ASN. You want to tell us a little bit about exactly what that was and how it plays into the process?
Yeah, so it's interesting because, we've talked in the past about how Congress is supposed to work and how any sort of funding bills are supposed to start in the House and then go to the Senate. And that sort of historical process has not been followed as closely of recent. years, but it's still sort of how we think about things. Similar with the ABIM and the ACGME. So as you think about potential changes to any specialty or subspecialty, it's supposed to start with the ABIM and then move to the ACGME. And what was interesting was earlier this year, both ABIM and ACGME asked the community for input on a couple of issues. So from ABIM, an issue that they asked for input on was, should they continue to include within the certification process expectations for knowledge in a set of procedures, and those procedures are then required as part of training in nephrology fellowship programs by ACGME. So that was kind of one issue, and there's a number of sort of current procedures that are part of the training and the certification, but also ones that have been suggested. So that was kind of one issue. And then the ACGME said, every couple of years, I think it's 5 years, they renew or update the requirements for fellowship training in internal medicine. And most of those requirements are pretty consistent across all the different fellowships, but then there's various specialties. There's a very specific set of requirements that are, in our case, for nephrology. And so they had come and said, we're thinking of, we're in the process of doing a renewal and sort of updating those. What does ASN think on that issue? And so, that was an interesting opportunity for us to say, well, wait a second, the community's been having this debate about what procedures should look like in training and certification. We've also been having a conversation around kind of ways to update the training requirements to include things like more exposure to home dialysis, just to use one very concrete example, but that's certainly not the only one. And there's also been a third set of topics. So there's the procedures one. There's the issue around, how do we update the curriculum to make it relevant for practice today, and using home dialysis as the example. And then there's also been a lot of discussion around, should there be subspecialization in nephrology that looks similar to, say, let's just use cardiology as an example. And we already have kidney transplantation as a subspecialty, but that's not an official ACGME one that's then recognized by ABIM. And so that's sort of the third issue that came up. And so in our response, we said, these are really important issues. You're at a real seminal moment in the history of this specialty. We'd very much like to work with the rest of the community to come back to you with sort of an overall vision of what we think nephrology should look like in the future, both from, specific content areas, but also, addressing the procedures issue, but also thinking about the subspecialization issue. We'd like to come back to you with some recommendations, and that can then help frame how to answer these questions around accreditation and what the criteria should be for training, but also then for certification and maintenance of certification.
You said something that I could, in my mind, hypothesize an answer for too, but it would be more useful to actually hear it from you. You used the term, I think you used the term just now, a seminal moment, or something of that nature in regards to kidney care. And there's a lot of different reasons, I think, mentioned in the letter that ASN prepared to ABIM and ACGME. But in your thoughts, kind of how does the changing world impact this whole discussion?
Yeah, I do think you and I are going to have slightly different answers here, and I don't think they'll be in conflict. I think they'll align. But I think if you asked anyone in our community what they think is changing both today, but is likely to change in the future, they'll probably identify the same set of things. So as we think about that, and I sort of reflect on ASN's letter back to them, the types of things that we identified as changing kind of the specialty. One was, we don't really know how the COVID-19 pandemic will affect the kidney community, both in terms of our patient population as well as the workforce in nephrology. So I think that's one very large issue. I think a second is then, how will training change as a result of the pandemic? And, we now have a group of residents and fellows who mostly only been training within the context of the pandemic. And what does that mean? I think a third is really this workforce issue. And recently the Association of American Medical Colleges redid their estimate and said that by the end of the decade, we'll be short 140,000 physicians in the United States. And so what does that mean for the role of physicians as well as other health professionals? And then specifically in nephrology, what does that look like? The fourth issue we raised was just around, and this is where you're the expert, is around everything that the Centers for Medicare and Medicaid Services are doing in terms of both the request for information that we've talked about before about sort of the future of the specialty, particularly around transplantation, but not limited to transplantation, but also the different care models, the voluntary model and the mandatory model. And then also, all the changes on the for-profit side in terms of, the recent news in terms of the Fresenius Cricket Interwell Health, just as one example, but just everything that's happening around value-based care and how that's going to change sort of what we think of in terms of the future of how kidney care is going to be delivered. Those really were the big reasons. And then also, we are at this moment where we are thinking creatively about what can we do to improve healthcare justice in this country and recognize all the social determinants of health for the healthcare population in general, but particularly for the kidney population. So those were the types of things that we raised with ACGME and ABIM. Just sort of curious if you think that's a reasonable sort of list.
It is the exact list that I would have made as well. And I might have, we probably assigned different weights to each one of them in terms of how important it is. But that a lot has to do with just our perspectives are colored by how much we work on something. And I do work on that transition into value-based care and into the care models in a very, very large way. And all the things that we look at in terms of the shortages that are currently occurring in the workforce are really just mounting up. We have watched on the policy side for quite some time the question about training in things such as home dialysis exposure in that process. As a matter of fact, just was in a meeting just on that subject matter just a couple days ago, and it really is something I think that a lot of people are trying to get their heads wrapped around. But aside from that, you pretty much ask them to give you a period of time to kind of come up with a more integrated set of recommendations, or would you characterize it differently? And what did ASN ask for?
Yeah, so it's a good question. So, what we thought was we needed to sort of set the clock. A lot of these conversations have been taking place for quite some time. It cuts across a lot of what ASN does related to undergraduate, graduate, and continuing education, as well as you said, the policy arena, as well as everything related to diversity, equity, inclusion, and healthcare justice. And so as we sort of took a step back, we thought, okay, let's really try to think creatively about ways we can bring the community together here. And so what we said is by October, we'd like to come back to ACGME and ABIM together, as well as to the entire community. And this aligns well with the timeline for Kidney Week in early November, with recommendations about the future of nephrology as a specialty, and think about, well, what are the core skills, knowledges, and experiences in the specialty that we think, moving forward, should we reconsider this idea that nephrology has one pathway for accrediting residency training and one for certifying nephrologists? And should we think more like the cardiology model or the kidney transplant model or something else? And just let's have that conversation and see if there's consensus and ways to improve care if we were to do that. We also, really need to look at there's a lot of data around sort of current gaps in training and a little bit of a misalignment between what's emphasized in training and what's emphasized or what happens in practice. And so, we keep using home dialysis as an example because it's a good one. What is that recommendation of sort of recalibrating training as a result of these other ideas? And I think if we do that successfully, and again, this is a very short timeline, but our thought is if we can come forward with a high level, here's a set of recommendations, that will then answer the questions we were asked about procedures from ABIM and about sort of changes to the training program requirements by ACGME. So again, by October, come forward with those recommendations.
That is a lot to orchestrate in a very short amount of time. And as long as I've been at ASN, this has been an ongoing conversation. You're right. We talk about home dialysis a lot now and have been for some years. But my point is to you is just kind of how many major kind of like what are your top of mind issues that you think are really going to be 3 to 5 top of mind issues that you think are going to be really challenging to deal with?
So it's there's an expression by former Representative Maurice Udall that if you find something everyone agrees on, it's wrong. And I think that applies here. It's unlikely that we're going to have unanimous consensus. We are going to establish a task force. Former ASN President Mark Rosenberg, who has spent a lot of time working on these issues, has agreed to chair it. But I think, it's going to be hard to say, just to give you 3 areas where I think you're going to have disagreement. I mean, one's going to be, should nephrology remain as a sole, that every nephrologist trains and practices sort of within the same parameters, or should there, the traditional model, or should we look at more of a cardiology model with subspecialization? I think that's issue one. I think the second issue is, what is the role of the nephrologist in the future? I mean, this is very much starting with thinking about the nephrologist role, but then there are other physicians that are involved in the care of people with kidney diseases, as well as other health professionals. And I think there'll likely be changes in terms of the historic or traditional role of the nephrologist versus, what the nephrologist might be doing in the future. And it's going to be hard to imagine that there'll be, unanimous consensus around that. I think the third issue that's likely to come up is how best to emphasize not just sort of the role of the nephrologist, but what constitutes nephrology care today. And is it, where is the focus going to be with or without sort of the subspecialty piece? So, I think of these as sort of the three big issues that the task force and ultimately the community is going to have to grapple with.
The different ways in which that could parse itself out kind of boggle my mind. And I start segmenting them into private practice nephrologist, and also what happens within a hospital structure. And this is all just a few of the things that pop into my mind right away. But this sounds like a very tall order.
It is a tall order. I mean, my feeling is the community's been grappling with these issues for years and hasn't reached consensus. And I think the reason we haven't reached consensus is because there hasn't been a timeline in terms of, you have to make this decision by this date. And I would argue that if we don't reach consensus soon, then these regulatory bodies, the ABIM and the ACGME, are going to make the decision for us. And I think it's important for the community, for the kidney community, to govern itself and to say, this is what we think constitutes excellent care for the millions of people with kidney diseases.
And that's where my day-to-day operations kind of come into that, because I'm keeping my fingers crossed that this goes well, because I think those of us who work in policy and a lot of the ASN members who contribute to our policy efforts in committees and in other ways really want to be able to point to some really clear indications of what comes out of this as we talk to the bodies that regulate and as we talk to people who make decisions on Capitol Hill. And I think that I do believe that things of this nature are part of the way a society works. And it basically gives you some input back to the decision makers. Okay, here's what the independent bodies have reviewed and decided makes the most sense in kidney care, and how they would like to see people prepared to execute that, and how programs should be structured in order to execute that. Is that overly simplistic, or does that ring at all true with you?
It does. I mean, I think that the challenge is, the way certification and accreditation work is they're looking at things in this moment in time and how care is delivered. And so if we come forward and say we think this is where the specialty is going in the future, there's naturally going to be a tension between that vision and what the regulators, the accreditors, and the certifiers can do. So I think that's challenge number one. I think challenge number two is, the good news is there's a lot of data out there in terms of what recent fellows wish they had more exposure to during their fellowship training, and looking at those data and really understanding what makes sense as to as we've talked about. I mean, there was a wonderful story by there was a wonderful JASN article in 2017 by Robert Rope and other colleagues, and they really did this survey and assessed it. And what they came forward with was, it was home hemodialysis, PD, ultrasound interpretation, acute GN, obstetric nephrology, toxicology, just kind of going down the list, renal pathology interpretation. Those were the top ones, and then there's a bit of a drop off. And so, as you start to think about maybe shifting more in that direction, what does that mean in terms of the relationship between nephrology and other specialties? And I think that's a really interesting conversation too.
Well, you've given us a great deal to think about. There is a lot there. It's going to make Kidney Week even more interesting this year, I think. You picked October as a deadline, we're right before we get to Kidney Week in October. We're going to see the celebration of the 50th anniversary of the ESRD program in federal law. So anything you want to leave us with in parting words?
Yeah, it's interesting. I hadn't thought about that anniversary in with relationship to this effort. But I do think, 50 years ago, Congress and the Nixon administration came forward and said we have this amazing artificial kidney, as they saw it then, and we can provide this service to everyone in the United States, regardless of age or means, to stay alive if they have kidney failure. And now 50 years later, I think the community's saying, let's reassess what it means, what it means to be a nephrologist, and sort of what this specialty looks like. And I think that's really exciting.
I think so too. Well, thank you very much for this today, Todd.
Thanks, David. I kind of like this approach. Maybe we'll try it again in the future.
I think that's a good idea. And we're definitely going to need to revisit this issue as it gets closer to the time to unveil that for the public.